start now. So hello, everyone, and thank you so very much for coming by today. Welcome to the Pearls Lecture Series of 2023. My name is Bilal Hafiz. I'm a third-year medical student at the University of Melbourne. And before we get started with our lecture today, I thought we'd quickly talk about Pearls as an organization, especially if you're new to our lecture series. So PEARLS stands for Focus for Emergency, as well as Acute Care in Resource Limited Settings. We started the PEARLS program last year. The inaugural PEARLS course took place in Vanuatu, in which we had a team of Australian and New Zealand physicians, as well as sonographers, go to Vanuatu and conduct a 3-day course, a rigorous course in ultrasound. And this took place last year. And since then, we've actually expanded quite a lot to different parts of the globe. So we're in Tonga, we've had coaches in Papua New Guinea and Kiribati, and we're currently expanding from PEARLS ED courses to critical care courses as well. So it's been a very exciting journey that we've had in 2022 and 2023 now, and then we look forward to expanding further. So after we run PEARLS courses, we try to ensure that we have continuous feedback by remote imaging modalities as well. And since then, we've also put the lecture series into place so that we can continue supporting physicians and other allied health staff from resource limited settings in their acute care provisions. So today we're going to be discussing gallbladder pathology, and this will be given by Joe McCann, who is a big part of the PEARLS program in the first place. So Joe, for some of the people who might be new to our lecture series, perhaps it'd be nice if you can just give us a quick rundown on how you use ultrasound in your day-to-day practice, and perhaps, how you got into it and how you see ultrasound changing clinical practice within the future as well.
Thanks, Bilal. So my name is Joe McCann. I'm actually a sonographer and a clinical lecturer for Otago University. So I use ultrasound 2 different ways, of course. As a clinical sonographer, I use ultrasound every day. But what's been really exciting for me in my ultrasound journey was when I was appointed clinical lecturer for the point of care ultrasound programs at Otago Medical School. And that's opened a whole new way of ultrasound for me. And it's really exciting to be able to teach and assist people learning ultrasound. And with it being quite focused, where you answer a clinical question, whereas for me, clinically, I often have a sort of general question in mind. So it's been really fascinating for me. And that's also, of course, opened up the whole outreach side of things to me, which I really enjoy, being able to travel and to assist people in resource limited settings. So it's very exciting. I love my job. I've been in it for quite a while, and I'm just very grateful that I still find it exciting and interesting after all these years. So hopefully I can share some knowledge with you today. Thank you.
Amazing. Thanks for that, Joe. What great insight. So without further ado, please, whenever you're ready, get started, and we look forward to hearing more from you.
Sure. Thank you, Bilal. And thank you, everyone, for joining me today. I'm just going to take you through a basic ultrasound lecture on the gallbladder. So before I start talking about the gallbladder, there's just a few things I would like to run through with you. Sorry, excuse me, I'm just going to minimize this here as well. So first of all, I like to talk about transducer grip. We can see that with the butterfly here, that they're holding it quite low down at the base. And I think that's really important. I think new users of ultrasound often hold the transducer much higher, and that limits your ability to control the transducer and to maintain your grip or your position on your patient. So hold low, just a little bit like a pencil. And you can see here, this is me scanning an abdominal patient, and I'm actually holding the transducer very low here. And I'm also have my arm resting on my patient, and I find that quite useful from a ergonomic point of view. I've got really relaxed fingers. I'm holding that transducer low, and I'm resting on the patient. Now, if that's not culturally appropriate for you, what you can do is place a wee towel between you and the patient, so you still have that support from the patient, but just gives you that little bit of distance. I think one thing that people, when they're new to ultrasound, they tend to use big swinging movements of the ultrasound transducer. But I think it's really important to try and remember to just use little micro movements, just adjust your transducer slightly rather than those big movements. Now, ultrasound safety is a really big part of my job. And what we adhere to is the ALARA principle, which is as low as reasonably achievable. So no matter what ultrasound I'm performing, whether it's an obstetric or whether it's an abdominal one, I've always got this in the back of my mind. And so part of adhering to the ALARA principle is that I think about the preset. So I must use the correct preset. And what that does in the background, it sets your power levels and your intensity levels. So it's actually really useful to do that. An acoustic window is really, really important. So that's thinking about what's the best window to image whatever structure you're looking for. Now, optimization, I talk a lot about optimization, anyone who's listened to me lecture before, and that's thinking about your depth and your gain. If you've got a focal zone on your ultrasound machine, some of those of you with cart-based machines will have a focal zone, have that set at the appropriate level, and also think about your frequency. So it may be changing to a penetration mode or lowering your frequency, and that allows the ultrasound to penetrate further into the patient's body. Particularly important when we've got, certainly for my practice in New Zealand, we've got much larger patients than we've ever had before, so we need to lower the frequency. Now, all these things help with ALARA, and also your dwell time, and that's how long you keep your ultrasound transducer in the one spot. So if you ever watch a sonographer, we're moving the transducer all the time. We don't have it sitting in one position at one time. And the other thing to consider is Doppler use. Now, the use of color or pulse wave Doppler really increases the intensity of the ultrasound beam. So that will raise those levels of intensity. So all of these things together are useful things to consider when you're thinking about ultrasound safety. Okay, so let's get on to the gallbladder. So I'm not going to go into the anatomy, but just a wee diagram here showing you the fundus, the body and the neck. And of course up here is the fundus of the gallbladder, the body and the neck here. And sometimes you can see right down into the cystic duct coming into the common bile duct. No matter what you do in life, preparation is always important. And if you're using a cart-based system, I would select the curved transducer. So that gives you the lower frequency and allows you to penetrate the ultrasound beam further into the patient. I would use the abdominal preset. Ideally, I like to have my patients fasted for at least 4 hours. Now, I understand for those of you who are in urgent care or in the emergency department, that can be a little bit tricky because the patients come as they are. But ideally, a bit of a fast is useful. That allows the gallbladder to have some bile in it and also to minimize the bowel gas as well. Now, I start my examination with the patient supine, and then I will also look in decubitus view as well. If you have a butterfly, select the abdominal preset here. And if you've got a larger patient, consider using this deep abdomen, and that will lower the frequency. So that's much like using the penetration mode that I talked about in the previous slide. The transducer movements I'm going to use is I'm going to fan. So that's anchoring the transducer in one spot and fanning out either side. Then I'm going to rotate the transducer, and then I'm going to slide up and down the gallbladder. But we'll talk about that in a little bit further on. The imaging sequence I'm going to do is I'm going to perform supine. I'm going to look at the gallbladder in the long axis. Then I'm going to evaluate it in the short axis. I'm going to roll my patient up in the decubitus position, and you can see that image there, that my patient has got their arm up over their head, and also they've got straight legs. And what that does is it just straightens this area out. When you roll patients on their sides, they often bring their arm in front of them and then bend their knees up, and that just scrunches that all down together. So getting the arm up will give you a bit more of a window and ability to have a look through the gallbladder and through that area. So once I've got them in the decubitus position, I then repeat that long axis view and the short axis evaluation. I do my wall measurement in the short axis view and the decubitus view, and then I'll have a look at the common bile duct. But this will make much more sense as we go through this talk. So as I said, I will do the supine view, I will do the decubitus view, but sometimes if your patient's not well enough and you can't roll them up on their side, or sometimes if I'm not quite sure what's happening in the gallbladder, then I will sit my patient up. Now, most of my patients come to me with a bit of pain relief on board, so they can sit up or they can stand up for me. But when they present to you in the emergency department, they may not be able to do that. So just consider if you can bring the back of the bed up, if you can put some pillows behind them, if you can tilt your table, all those things will move the position. And why is that important is because if we just looked in the supine position, and these two gallbladders are the same gallbladders, and if we just looked in the supine, we'd be going, oh, okay, that's fine. There's no pathology in the gallbladder. But once we've changed that position and moved them into the decubitus view, or even if we've just set them up, if that's all that you can manage, then suddenly we can see that there's some calculi within the gallbladder. So it's really important to change that position. So the gallbladder can be challenging to find. It usually sits the mid-clavicular line, and sometimes if we can get the patients to change their breathing, that can help as well. So for those who haven't scanned gallbladders before, this is the way that I teach to find the gallbladder. So I'm going to find the xiphisternum on the patient. I'm going to place the transducer in the longitudinal plane, and the marker of the transducer is going to be towards the patient's head. Then what I'm going to do is slide down the ribs here. And as I slide, that marker is turning and it's actually facing towards the patient's right shoulder. Now, getting the patient to breathe in and hold it might help if you can't see it. But even with that, sometimes it's a little bit hard, and you may need to return to the xiphisternum and slide across the ribs. And what we're looking for is an anechoic structure. Okay, so this is a wee video of what I do. So you can see I've palpated the xiphisternum on the patient. I've got the marker towards the patient's head, and I'm sliding down along the costal margin. And my transducer is rotating slightly towards the right side, to the right shoulder. Sometimes if I'm really struggling to find the gallbladder in the supine position, I'll just come in. So I'm on the side, much like you do when you're looking for your FAST, you're looking for your right upper quadrant view. And I've got the transducer in between those two rib spaces there. So then I'm going to roll my patient to the decubitus view, and I'm just repeating that view again. So there we go. I'm sliding down, sliding along the lower costal margin. And my transducer is just starting to rotate towards the patient's right shoulder. Okay, so what do the ultrasound images look like? Now, part of the evaluation of any organ you're doing, but in this case we're talking about the gallbladder, is borders, boundaries, and beyond. So it's not sufficient just to put your transducer on and see the gallbladder and not look any further. So let's have a look and see what I mean. So here we go. I'm identifying the gallbladder, and what I'm doing is I'm fanning through one way and then all the way through the other. So that's borders, boundaries, and beyond, doing a full evaluation. So this is the fundus of the gallbladder. This is the body, and coming down to the neck. And it's really good if you can see right down to the neck, because there may be a stone stuck down there. Now, for those who aren't used to ultrasound of the right upper quadrant, this is the liver edge here. And this structure here is the portal vein. It's an anechoic tube coming into the liver with some bright echogenic walls. And we'll talk about that a little bit further on in my talk when we talk about the common bile duct. So you can see that I'm fanning borders, boundaries, and beyond, looking all the way through that gallbladder. And now what I'm going to do is I'm going to rotate the transducer so the marker comes towards the patient, towards the machine, and then I'm going to slide. Now, the reason why I'm sliding in the longitudinal plane is if we think about the way the gallbladder lies, it lies on an angle. And we've lined up along the long axis of the gallbladder. So not the long axis of the patient, but the long axis of the gallbladder. And so if we turn onto that into the short axis, if you fanned, you wouldn't be able to see that very well. So what we're going to do is slide, and we're going to follow the line of the gallbladder. So we can do borders, boundaries, and beyond in the short axis as well. So here we go. I'm starting down low in the neck, coming up towards the body and right up to the fundus. And you can see again that I'm sliding up the gallbladder, and it's borders, boundaries, and beyond. So I do that, as I said, in supine. and in decubitus as well, to ensure that I fully evaluate the gallbladder. Now, I've mentioned that we do a wall measurement, and how we take that is in the decubitus view, and we're measuring the anterior wall of the gallbladder. Now, some people I've noticed, and in some instructional videos, you'll see that people do that in the longitudinal view, and they do it over here. But if we think about back to ultrasound physics, the most or the best resolution is when the ultrasound beam hits a structure at 90 degrees. So if this is the center of our image, the ultrasound beam is coming down at 90. And so that's going to be the best resolution here. So that's why we measure here, and it's just outer wall to inner wall there. And that's what I call the 90-degree rule. And we use that in lots of other things as well. And a normal gallbladder wall is less than 3 millimeters. But it's really important to optimize your image. So you want to use that zoom before you freeze function. So don't freeze it and then zoom it up, because all you're doing is just blowing up the pixels that you've got there. But if you zoom before you freeze, you actually add more lines of sight to your image. So it's going to be a much better image and a much better resolution. And of course, the other thing is, no matter when you measure, is be careful with your caliper placement, because it's very easy just to place it slightly incorrectly and you'll overstate your measurement. Okay. So one thing about measuring, sorry, I didn't say that we measure at the fundus of the gallbladder, but if you're too far up towards the fundus, we've got this fascia line here. So you can see that echogenic white structure there. And if we're up too far into the fundus, then it's very difficult to see what is the wall and what is that line of fascia. So by just coming back inferiorly off the fundus of the gallbladder a little bit, and you can see some liver coming over the top here, and then you can see that wall nice and clearly. So again, we're in the middle of the image so that the ultrasound beam is hitting at 90 degrees for the best resolution. And then you've got the most accurate measurement you can get. So I'm going to talk to you a little bit about some of the common pathology that we'll see. So I often find sludge. So here's some sludge here, and these patients are usually asymptomatic. It's not the cause for a patient with right upper quadrant pain. You'll see some low-level echoes. Won't see any shadowing behind there. And this is usually mobile, but often quite slow. So when you move your patient from the supine to the decubitus view, that might take a little bit of time to layer out. Polyps are fairly common. And the important thing here is to see whether they shadow, because you can muddle up polyps and stones. So that's another reason why we move from the supine and the decubitus view and look to see if there's any shadowing as well. And I've just had a run of some gallbladder pathology. So I'm just going to show you this wee cine here. This is the liver here. This is the gallbladder coming round like this. And we can see those little polyps sitting there. So I'll just run that through again. So there's a wee fold in the gallbladder, but here's a polyp and here's a polyp. Lots and lots of polyps. And if we have a look in the decubitus view, so here's the gallbladder. The shape looks slightly different because we've rolled the patient, but those polyps are still in that same position there. So several polyps. So that patient will come back to me in a year's time for another ultrasound, but just a target ultrasound of the gallbladder. Cholelithiasis, I guess this is the one that we're really interested, trying to figure out whether there's a acute cholecystitis. So we've got a fairly big stone here and we've got a shadow behind that, so we can be confident that that's a stone. If you have a look at the gallbladder wall, so here's the gallbladder wall around here. If we have a look in this one, for example, that's thin, as is this one here, but over here we've got an edematous wall. Now moving back to this one here, we've got some large stones where we've got some shadowing, but we've got some smaller ones where we can't see a shadow behind it. And this one here, I've rolled my patient, so I definitely know that's a stone, but we've got no shadow behind it. So that makes it a little bit tricky for us to work out. But remember, 20% of gallbladder stones don't shadow at all. Excuse me, sorry. Okay, so let's have a look at this one here. This is one from yesterday. So here's a gallbladder here, and we can see some stones there and some sludge. So I'll just run that again. So sludge and stones, and this is a longitudinal view of the gallbladder. And here we go, here's the transverse view, and there's the sludge with the layering and the stones there. But if you have a good look at the gallbladder wall here, it's very thin, so we don't have a cholecystitis situation, but we have some cholelithiasis and some sludge. Okay, so acute cholecystitis, I think that's probably the most common question I have with patients coming from the emergency department. And these patients will have cholelithiasis. This one here's got some sludge up here. They'll have a thickened gallbladder wall. We can see that this gallbladder wall is thick here. Gallbladder might be a little bit bigger than what we expect, and they may have some pericholecystic fluid as well. So if we follow the outline of the gallbladder here, so we follow around and then look up here, we can see a little bit of fluid up here, and we follow that wall around here, whereas this one here, we can't see any fluid there. But down in the neck here, we see a little bit of shadowing, so you'd be suspicious that there'd be a stone there. And here is the short axis view of the gallbladder with an edematous wall there. And of course, one thing we want to know as well is what's happening and whether they're mobile. So here we go through here. So longitudinal view there of the gallbladder. We can see the liver here, kidney over here, and look at that wall there. So when that plays again, just have a look at how thick and edematous and echogenic that wall is there. And if we turn into the short axis view, we can see, look, that's a very edematous wall. And this patient has acute cholecystitis. And the other thing we want to know is whether they have a sonographic Murphy's. Now, I've had a few patients through with right upper quadrant pain, and they've been seen in ED, and they've been felt to have positive sonographic Murphy's. But actually, when I scan them, their pain is actually in a different position than when I'm scanning the gallbladder, and it turned out to be a bowel issue rather than a gallbladder issue. So it's important also to make sure that when you're scanning, just to check that the pain is actually coming when you scan the gallbladder. Can, of course, get acalculous cholecystitis as well. So we've got a thick-walled gallbladder, but we can't see any stone. And when you pop colour Doppler on, you can see that it's quite hyperemic. Now, this was an interesting case I had. I think it was last year. This patient was very frightened of contracting COVID if they came into hospital. So they stayed at home and got sicker and sicker and eventually had to come to hospital. And what they did was they actually perfed their gallbladder wall here. So if we follow, this is a short axis view of the gallbladder, and we follow around, we can see wall here, and we can see wall here and around here, but we can see the gap there. And so this patient had actually perfed their gallbladder. Another thing you might see as an example of chronic cholecystitis is a Weir's triad, and that's a wall echo shadow. Now you have to be careful that you don't confuse bowel, because bowel and duodenum sit in here up in the right upper quadrant. But what you look for is you look for this line. So here's the line here. So this is a longitudinal view of the gallbladder. We've got the gallbladder wall there. We've got a little bit of bile there, and we've got this echogenic structure here. But I think really the key is the shadow, and we'll talk a bit more about shadows in another slide. But here is the shadow. It's a really strong acoustic shadow, and that means that the sound isn't able to pass through the gallbladder or the stones, and it's being bounced back to the transducer. Okay, so that's just a little bit of a rundown of the most common pathology you might see, but here's some troubleshooting things that you can use if you wish to. So this is the same gallbladder, and all I've done is asked the patient to take a breath in, and look what a difference it makes. So we can't really see the neck of the gallbladder. We've got a whole lot of gas around here. Can't really see the portal vein here, but they've taken a breath in. And look, now we can see the gallbladder right up to the fundus, around and down to the neck. Might be a little bit of a little stone down in the neck there. And we can see that this is this structure, echogenic structure, is actually outside of the gallbladder. So it's not a stone. And we can see that portal vein nicely. So don't forget to ask your patient to take a wee breath. So sometimes I get them to take a wee breath, sometimes I get them to take a big breath, just depends. I'll try anything and see which one will work. Is the stone mobile if it's stuck down in the neck? So we've talked already about if your patient is unable to roll into the decubitus position, that we can maybe bring the back of the bed up. We can tilt the table if you've got a tilting table. Another option to do is ask the patient to take a breath in and push their tummy out and make it quite fat to see if we can move that stone, changing the breathing. Or what I used to do a few years ago, I haven't done it recently, is get the patients on their hands and knees on the table, and that actually just moves that moves the gallbladder into a slightly different position, and that stone may roll out of the neck. So I've talked before about the acoustic shadow, and this is the example I showed you. So we have a stone here with a really strong distal acoustic shadow behind it. But if we have a look over here, sometimes because we're right, the duodenum is right in the same position as well, people can be a little bit confused by this here and think that this is a shadow coming from something in the gallbladder, but that's actually small bowel. And you can see that rather than it hasn't got that blackness of the shadow here, it's actually quite dirty or quite messy. And I think sometimes I can be confused by this as well. And what I do is I just sit on that for a little bit and look to see if the bowel peristalse, because if it's bowel, it's going to peristalse and move away. But somewhere along the line, you'll get caught out by that. I think most people do. I certainly did when I was a student. So we've talked about a shadow and wanting to be a shadow, to see the shadow, but sometimes you can't actually see a shadow. So there are a few things that you can do with your ultrasound machine or your patient to help you with this. So I've talked already about a zoom before you freeze box, so make your image larger, but use that zoom that will give you more lines of sight within your image. Take your compound imaging function off. Now what compound imaging does is it smooths the image out. So this is a very smooth image. It's all very even. And these are some gallstones here, but you can see behind that, it's very difficult to see whether that's a shadow. Is that a distal acoustic shadow, or is that a bowel shadow? So by taking that function off, and that's available on Butterfly, that you can remove that. On Sonosite, it's called multi-beam. If you have a Philips cart machine, it's called Sonos CT. It will be there somewhere, and if you're not sure, take a picture of your machine, and you can always send it through to me, and I'll have a look for you and see if I can figure it out. But so here we've got those same gallstones, and the difference between here and here, well, I've zoomed it up using my zoom before I freeze button, but also I've taken that compound imaging off, and look, I can really make those shadows out now. And of course, imaging in more than one plane is very important. Sometimes that can help you figure it out, and in more than one position as well. And also, you can also use twinkle artifact with color Doppler, and we'll move on to the next slide and explain that. So twinkle artifact is using color Doppler. If you have a focal zone set it below the stone, use a color Doppler box, a small one. This one's probably a bit too large, actually. I'm probably half that size. And what we're looking for is this here. So this is color aliasing. So you can see that you've got the reds and the blues up there. Sorry, the other way around, which is what we usually see. But here, there's lots of aliasing there, and there's a wee stone there as well. And so that's what happens when you see a stone, you'll see that aliasing behind it. Now, the sensitivity is better for small stones using color Doppler and the twinkle artifact than distal shadow. But this is something that I don't use for everything. It's not very good for large stones, and you should be seeing that distal shadow. And it's just something, one of those things that I keep in my back pocket. If I'm really struggling, I'll pop it out and see that it helps me. But that again depends on the quality of the machine you're using and how good the color Doppler is. Now, on my big radiology machines, my color Doppler is really good, but on some of the smaller point of care ultrasound machines, it's not quite so good. And of course, beware the small bowel. Now, I've mentioned already that the small bowel sits in that spot where we expect to see the gallbladder. So there's the tip of the liver coming down. This is the portal vein here, hepatic artery, bile duct coming over the top. And I had a student give this to me and say, oh, the patient's got a Wes artifact. So you can see that you can confuse that, but actually fanning through, making sure that you're doing a really good evaluation in supine and decubitus, taking your time, not just putting your transducer on and going, yep, that's it, tick, I've seen it. And by fanning through, we can actually see here's a wee gallbladder sitting there, and this is the bowel here that we can see over there. Okay, so there are always some pitfalls with ultrasound, and that's one of the things I really love about ultrasound is we'll have a set of rules and some ideas, and then there will always be something that will trip you up. So I've just got a couple here for you. So one of the congenital variants is a Phrygian cap. And so here's the gallbladder here, and we can see that it just flops over the top. And you need to be a little bit careful because if you don't look through carefully, you might think that up here is the fundus of the gallbladder, whereas actually it's up here because it folds over itself. And it's relatively common, and you will see it. And I had a beautiful example come in a few weeks ago, so I've got a wee cine for you here. So liver here, this is the gallbladder. We've got a wee stone down there. And look, here's the Phrygian cap with some stones here. This is duodenum, small bowel. So I'll just play that for you again. So here we go. And it flops over. So if you're not reviewing carefully, you'll miss those stones up there. And here's the other view here. So short axis coming up, we pass that stone down there. And look, the Phrygian cap actually flops over to the side. So again, it's just recognizing that it's really important to actually look through properly and evaluate fully in those two planes. And going through and past the structure that you're looking at. Septations are really common, and whilst there's not too much of a problem with it, what some people do is, if you're not lined up on the septation properly, is they can mistake this for polyps, but it's very unusual to have polyps sitting directly opposite one another. And if you just tweak and use those micro movements of your transducer, you can line that up and join that up so it looks more like this image here. Now, I've talked about 3 millimeters being your normal gallbladder wall. And if you've got something that's larger than that, well, it may be because of cholecystitis, but there's also actually a large number of other things that may be causing that. I think for me, the most common is congestive heart failure. I see that quite a bit in my practice, and also cirrhosis as well. And so anything with ascites or lots of fluid will make that gallbladder wall edematous. So HIV/AIDS, hepatitis, dengue fever, renal failure. So just because you've got a thick gallbladder wall, make sure that you're evaluating the gallbladder properly, and you're putting it within your clinical picture as well, because of course imaging, you don't just take imaging on its own, it needs to fit within the clinical picture that you see with your patients. And just another wee comment about gallbladder wall measurement. I've said that we measure it closer to the fundus. This is a gallbladder wall down near the neck, and we can see that the wall from here to here looks a little bit thickened, but actually it's just because we're quite low down near the neck of the gallbladder. So make sure that you're much further up by the fundus. Now this one was given to me by one of my students at Otago, and they were a little bit confused as to how to measure this gallbladder wall. So I think we can all see that this is the liver. This is the gallbladder here. We've got some stones down here, and the shadow's not very clear here. Now let's move on to the other slide. So this student wasn't sure whether they measured it here or whether they measured it from here to here. So they gave me both options and asked me on Moodle what was the correct one. So actually the correct one is B. So we measure and we include the edematous wall as well. So that's very much an acute cholecystitis with a very edematous wall. The other thing that's a little bit tricky is, for me, certainly in the radiology department, we ask our patients to be fasted. And so this patient came along. I just asked them casually when I'm getting them set up on the bed, or when did they last eat? And this chap said, oh, I didn't have anything today. Last had something to eat at 6 o'clock last night. But when I put by the time I got to putting my transducer on the gallbladder, this is what I saw. And I can see that it's a little bit contracted. And what I need to work out is whether that's a pathological thing or the fact that my patient had eaten. So one of the things that I was fairly relaxed about was the gallbladder wall throughout here looked fairly thin. So when I asked them again, it turned out that they had their last meal at 5 o'clock the night before, but actually they were a wee bit hungry, so they'd had a snack in the morning before they'd come to see me, and they'd had cream donuts and a latte, coffee, and that's why their gallbladder wall had contracted. So I'm quite comfortable with that. That's a normal gallbladder in that situation. Whereas this patient here had been starved for 12 hours prior to my ultrasound. And if I follow the gallbladder around like this, I can see these edematous walls. And as I come round here, I come round down here, and we can see a little echogenic shadow here, or a stone here with a shadow behind it. So this was actually a contracted gallbladder because of pathology. So just take your time and make sure that you're checking and evaluating fully, and also chatting to your patient as well. Sometimes you have to ask the same question several times before you get the answer, but I'm sure you're aware of that. So I've said to you that the gallbladder wall is an anechoic structure in the right upper quadrant, but beware there are a few other structures that you might come across. So again, making sure that you're evaluating fully and not just jumping to a conclusion. So this might be a transverse view of a very dilated gallbladder, but it is actually a cyst of the lower pole of the kidney. So the kidney sits further down here with the lower pole here, and this was a large cyst there. And over here, this was one that one of my students from Otago gave me as an example of the gallbladder. But when I looked at that, I thought that's a little bit strange. That doesn't really look like a gallbladder. So what they said was that this was the portal vein in short axis view, and this is the gallbladder here. But what I can't see is I can see a beginning here, but I can't see an end to it. And when I went and had a look at this structure, it actually carried on, and I couldn't find a gallbladder. I couldn't find an end to it. And what they were imaging was actually small bowel. So it's a common mistake, but don't forget to rotate 90 degrees, have a really good look, and this is the view that we want. So we want to be able to see the neck and the fundus as well. So that's a quick view, sort of run through of the gallbladder. And I'm just going to talk briefly about the common bile duct. And this is a really hard structure to teach you about how to find it and how to scan it on a lecture. It's much easier at the bedside, but let's have a go at it anyway, and hopefully it'll make a bit more sense to you. So the really important landmark, and I've mentioned this already, is the portal vein. So if we look here, here's the portal vein. Here it's an anechoic tube going into the liver with echogenic walls here. This is hepatic artery here with the bile duct sitting over the top, and this is the liver. And in short axis view, and we'll talk about this a little bit further on in my talk, portal vein there, common bile duct here, and hepatic artery there. And so here we go. So we've got the portal vein here, hepatic artery with the bile duct sitting over the top. Now, I find that pokers like to talk quite a bit about food, and the analogy that I've heard of for this is an olive sandwich. So this being the portal vein being a big piece of bread, with the olive being the hepatic artery sitting on the top and a thin bit of bread on top of that. So an olive sandwich. It doesn't really sound very appetizing to me, but there you go. And what you want to see is that the bile duct is actually a thin piece of bread. So that should be smaller and not as large as the portal vein. So how do I find it? I roll my patient into decubitus. So I've had a look at the gallbladder, measured the gallbladder wall in decubitus, and then I move on and have a look at the common bile duct. I find if I try and look at it in supine position, it's a waste of time because there's bowel gas and it's just much harder. So remember that rolling them up on the side allows their tummy to fall forward if they've got a large tummy, and take their bowel gas with them as well. So that tends to roll forward as well. So we found the xiphisternum, the transducer is in the longitudinal plane with a marker towards the patient's head. And I'm sliding along the costal margin, and that marker rotates towards the right shoulder. And what I want to find is that main portal vein as it enters the liver. And then I'm going to rotate between 10 o'clock and 2 o'clock, because depending on the bile duct and the orientation, and you just don't know until you start scanning the patient, that you might actually need to end up going around to 2 o'clock with a marker towards the patient's left shoulder to try and elongate that common bile duct out. So this is, you can see that I've got my patient up in the decubitus view. I'm scanning along, and I'm actually going to begin to rotate my transducer towards the right shoulder. And here we go here. Here's be easier to understand here. So we've got tip of liver here, sliding down. Here's the portal vein here as it goes into the liver. It's that anechoic tube with the echogenic walls, hepatic artery sitting on top there, and bile duct coming across there. So that olive sandwich again. Okay, so once you've identified the common bile duct, where are you going to measure it? So let's find that portal vein, hepatic artery, and here's the bile duct here. And we're going to measure it as close to the hepatic artery as we can, but also at the widest point. There's no point measuring it here where it's thinner. This is actually where it's fatter, so out here. It's also important to remember that we measure it extrahepatic, so we don't want to be measuring it within the liver. We need to make sure that we see the portal vein as it comes out and the bile duct as it exits the liver as well. And our measurement is going to be inner wall to inner wall. So what do we do inner wall to inner wall? Well, we can see that it's sitting right on top of the portal vein in this image. And so which wall belongs to the portal vein and which wall belongs to the bile duct? We can't really see, can we? So just inner wall to inner wall. And a normal measurement is less than 6 millimeters. Now, some people use 3 millimeters plus a millimeter per decade. But for me, I just like to keep things really simple. So we've talked about the normal gallbladder wall measurement is 3 millimeters. Common bile duct is 6 millimeters, so it's just as simple as doubling that. And then if you've got an elderly person or someone who's had their gallbladder out, then we add another 3 and it's 9. So it's 3, 6, 9. And I just find that so much easier to remember. And in this example here, we can't see the elongated portal vein very well, but there's the hepatic artery, and this is the bile duct here. So it's narrow as it's in the liver, but you can see it expanding out as we're getting extrahepatic, which again is one of those reasons why you measure it outside of the liver, extrahepatic measurement. Now, I've talked about the olive sandwich earlier, and with the big piece of bread and the olive and the little piece of bread, but now you can see visually that these two bits of bread are the similar size. So that indicates that this bile duct is much larger and dilated than a normal bile duct would be. And I think, sometimes we get, and I know my students at Otago struggle with measuring the common bile duct, but I think if you follow your technique, you find the Ziphi sternum, you slide down, you identify the portal vein, the hepatic artery sitting on top, then if it's large, you're going to see it. It's very hard to miss it, because look how big that is. You're not going to miss that if there's a problem with the common bile duct. If you do have a large common bile duct like that, you do need to have a look in the liver and see if there's any intrahepatic duct dilatation. Now, you may not be scanning livers, and it's a little bit of a specialized area, but you can see these are some extra tubes here. And what we say is there are too many tubes, and we've got lots of stuff happening here, which clearly doesn't look normal. Now, some of you I will have taught how to do, and the rest of the faculty, the PILS faculty, will have taught you how to scan the right upper quadrant for a fast ultrasound. So if you're thinking about that, we haven't taught you how to scan a liver, but every time you do a fast in the right upper quadrant, you see the liver every time you're scanning these patients, and you're building up an internal ultrasound library of what a normal liver looks like. So hopefully if you see some intrahepatic duct dilatation, you will think, hang on, that doesn't look like the livers I see when I'm doing a right upper quadrant. So think about what normal looks like. This is a right upper quadrant view with the aorta. This is the pancreas here and left lobe of liver. And this is what a normal one looks like. But here we can see that there's too many tubes there, and there's some intrahepatic duct dilatation. And it does tend to happen on the left side before it affects the right side. But just remember that every time you're performing an ultrasound, you're building up an internal library. Now, apologies for this image. This is from a friend of mine who was working in Africa, and this is the portal vein here. It's an old image. This is the hepatic artery here. This is the bile duct, and this is a wee little worm in there. And when they sat and watched, they could see it moving, and what it would do was pop back and then pop out again. And so sometimes, being mindful of Valara, you might need to sit somewhere to have a look and to see if you can see anything like that. Okay, choledocholithiasis. I struggle with this. We get patients come through from the emergency department. They've identified stones in the gallbladder. They know the patient has acute cholecystitis, but they still want us to assess to see if they've got choledocholithiasis. So New Zealand patients can be a little bit round and a little bit gassy as well, and it can be really difficult to see. But I can see already on this ultrasound image that I've got a portal vein there, hepatic artery here, and this bile duct is large. So I've got a dilated duct, and here we see some stones sitting there with distal acoustic shadowing. So that happened. I think this image is from about 10 years ago, and I don't think I've had an image like this again. It's pretty tricky to see these because of the central abdominal gas and the habitus of patients these days. But one thing to remember is that the bile duct actually goes through to the head of the pancreas. Now, this is head of pancreas here. If I outline the pancreas, this is the body, and this is the tail coming around here. So there's the pancreas there. And in longitudinal, it's through here. And the bile duct comes round and actually enters here into the head of the pancreas. So this is the bile duct, and that's the gastroduodenal artery coming into the pancreas. And this is it in longitudinal plane. Now, in patients that have got a really large common bile duct, and you just see if you can follow it along. Again, you might have some trouble with some bowel gas, but here's a really large dilated bile duct, which was a little bit easy to follow. We're following it all the way through to the head of the pancreas, and there's a wee stone in the head of the pancreas. So there was no stones in the gallbladder, but this one had got stuck in the head of the pancreas. So it's worth, if you can, follow it through. Okay, let's have a look at some troubleshooting. Not really many options here for troubleshooting for the common bile duct, but just a reminder that micro movements, particularly you can see how small that bile duct is can really help you find the common bile duct. The other thing is to consider, sometimes you see this, the transverse view or the transverse Mickey Mouse sign. So this is the portal vein here, with the bile duct and the hepatic artery and the IVC here. And I've got a wee clip of one here. So this is gallbladder here. Here is the portal vein. So you can see, and I'm turning on that, and there is the bile duct there. So transverse Mickey and rotate around. This is something I don't really use. I use that other method of finding the portal vein and the common bile duct. But sometimes when you're scanning the gallbladder, if you look a little bit further down, you can actually identify the bile duct sitting there, and then you need to rotate to elongate it to measure it. So no matter sometimes what you do, you actually just can't find the common bile duct. So things to consider: have you used a good technique? So I've showed you how I find it, and slide down and identify the portal vein. Have you got your patient in the decubitus position? Because I think that really makes a difference. You're really struggling if you're trying to find it in the supine. Have you had a really good look? Have you looked carefully as you're optimizing? Have you got too much depth that the string out is way down there? As your patient starts, that's a really good and easy to identify. If you haven't got any interest, then it's probably normal. And so maybe just say that it's a normal looking common bile duct, and that you're assuming that it's normal because you've been unable to identify it. Whereas we can see here, here's a portal vein here, hepatic artery here, and this bile duct is very large. And if you just look up here, you can see a wee bit of intrahepatic duct dilatation. Okay, so a couple of pitfalls. So I've mentioned to you already that we have a olive sandwich. And we'll have a look down through here. So here's portal vein coming through here. But have a look here. So we've got the round dot above the bile duct. So this is one of these situations where you have a rule, but there's always an exception to the rule. And so in a certain number, I'm sorry, I can't remember the percentage, but the hepatic artery actually sits above the common bile duct, but very small number of patients. And you can also get a duplication of that, and you'll see 2 circles there as well. So again, it's about having that good technique, identifying the portal vein, and then working from there. Now, I know that some people like to use color Doppler, and this is, sorry, my color Doppler picture video wasn't working, so I borrowed this from Mr. Google. And some people like to use color Doppler to definitely identify the bile duct. But I think if you've got that good technique, you don't need to do that, because I can see from the still image already that that's the portal vein, that's the hepatic artery, and this is the bile duct coming over the top, and this is the gallbladder. So let me just play this clip. So there we go. We can see bile duct coming over here, and they have put color Doppler on. One of my comments I would make is that it's a very large color Doppler box, and we don't need such a large color Doppler box. Just make it quite small if you are going to use it. When you use a large color Doppler box, it slows the frame rate down, so makes it very jerky. But if you have a look at this again, there's like a whole lot of things flashing all around, and it can be quite distracting when really you can identify. I can see that bile duct very easily, and I don't think you need to use color. But it might be one of those things you keep in your back pocket and pull out when you need to. Okay, so in summary, we've just had a quick run through from the gallbladder and the bile duct. Please remember borders, boundaries, and beyond, and that applies no matter what you're actually evaluating. So whether you're doing a kidney, whether you're doing a gallbladder, whether you're doing an aorta, always make sure that you borders, boundaries, and beyond. Review the gallbladder in supine and decubitus. I really can't stress that enough. If you're only looking in supine, that will trip you up. You'll miss pathology. Measure the gallbladder wall thickness in the anterior wall and the short axis, and that's that 90-degree rule. Now, I've talked quite a bit about identifying the main portal vein and finding the bile duct coming over the top. And we're going to measure inner wall to inner wall. And if it's dilated, if it's big, if you've got a big olive sandwich, don't forget to check the intrahepatic ducts. I think that 369 is really simple to remember. So 3 millimeters for the gallbladder wall, 6 millimeters for the bile duct, and 9 millimeters if someone's elderly or had their gallbladder out. And optimization is really, really important. Again, no matter what you're evaluating with ultrasound, please remember your optimization. Depth and gain really makes such a big difference, and that will help you with the ALARA. So please remember the ALARA principles: optimization, good acoustic window, and dwell time as well. So thank you very much. And